So what I thought I'd do is present a case study, which is an actual de-identified patient that I have had in my practice. I've pretty much treated, I would say, 90% of the patients in my practice, or I have referred them on for treatment if they've been complex. And I've become a port of call in my own practice. My colleagues tend to refer their patients to me. I figure that's okay because I've got a special interest and I'm really keen to do it. So this is a patient called Steve, who's aged 32. He was recently released from prison and he ended up coming back to our practice because his parents and his family were long-term patients of our practice. He requested an STI screen, so we were lucky in that case. We didn't have to go looking for him, but I think he actually suspected that there may have been a problem. So his infection was detected on an STI screen. I went through and did those tests as explained. He had positive hepatitis C serology, a positive RNA. His genotype was 1A, which is one of the more common genotypes, and he'd never been treated before. So we've established that there's a current infection and we need to go to the next step. I did his tests for co-infection. He was negative for HIV and had never been infected with hepatitis B. If I remember correctly, he was not immune to Hep B and was vaccinated. He was also not immune to Hep A, and I vaccinated him for that as well. So no co-infection, we can go on to the next step. So if we look at Steve's results in terms of assessing whether there's liver damage or liver fibrosis, all of his tests came back pretty normal, apart from some elevation in his liver function tests, the AST and the ALT. But he had a normal hemoglobin, normal platelets, normal INR, a normal bilirubin, and so on. You don't have to do an ultrasound. I like an ultrasound because it gives me more information on which I can make a decision, and his ultrasound was normal with no evidence of portal hypertension, didn't have a nodular liver edge, etc. If you're looking at these ways that we can assess whether fibrosis might be present, the APRI score, very easy to use. It stands for the AST to platelet ratio. You just use an online calculator and punch in the numbers. If the APRI score comes back at greater than 1, then there's a significant risk of the patient having advanced fibrosis or cirrhosis. You would have heard of FibroScans, which is a registered trademark machine that performs transient elastography. If the score is above 9, there's a high risk of advanced fibrosis, and if it's above 12, there's a high risk that the patient has cirrhosis. So what I'm going to show you how to do now is how to calculate an APRI score using an online calculator. So I would suggest this website, which is www.hepatitisc.uw.edu. That brings up Hepatitis C online, and you can go to the clinical calculators. And it brings up automatically the AST to platelet ratio index. So if we use the values that we got with Steve, his actual AST level was 46. The upper limit of AST is about 40. And then the platelet count for Steve was 249, and as you can see, his APRI score is 0.462, and that indicates a high probability that he does not have advanced fibrosis. So we've established that. Let's go to the next step. Steve was pretty easy in many respects. He was on no regular medications. He had no chronic medical conditions. He did happen to take a herbal preparation. And the good thing was that his partner had a Mirena IUD, so we can go to the next step. So the next step is to choose the treatment. Things have been made a lot easier now because they're pangenotypic treatments. The key step is to check the drug-drug interactions, and there is a specific website that has been set up to help you do this. This is an incredibly helpful tool that will help you establish whether there's any potentially significant drug-drug interactions. The website for this is www.hep-druginteractions.org. And we just click on this and it brings up this page, which is the interaction checker. Just click on that. So the first step involves putting in which drugs you are going to give the patient. So we might tick this one. And then I'm going to choose a couple of drugs to show you what comes up. So basically what comes up is a traffic light system. Green is go, amber is there may be some changes you have to make or modifications, red is don't prescribe. The medication I'm going to choose is the estrogen from the pill, which is ethinyl estradiol. And as you can see here, no interaction is expected. So you've got a green thing which says go ahead. So let's try another drug, esomeprazole. Green. All right, let's try another medication. So we can come back here and you can see what happens if you co-administer some of those medications. So the key one here, of course, is the estrogen that's involved in the oral contraceptive pill. It gives you a lot of information about what you can do. Sometimes what I do if people are on the pill and I really want to prescribe this medication, I will give the patient the option of having a Depo-Provera injection, which gives them 12 weeks of contraceptive cover, which pretty much covers the duration of their treatment. So there's lots of information there in terms of alternatives, etc. If we come down here, there's a potentially weak interaction with esomeprazole as well, and that'll give you more information. Some of the stuff that's got to do with PPIs is about the need for some of the medications to have stomach acid in order for them to be absorbed. A really easy, very informative website for you to check your drug-drug interactions. You should cease all unnecessary drugs that the patient is on. And the other thing is that you need to make the patient aware that if they are commenced on any new medications during the course of the treatment, they should touch base with you. The experience I've had with this is that one of my patients was started on quite a strong antibiotic by a dentist. Thankfully, she contacted me. I got her in, assessed her. I didn't feel she needed the medication, and that was helpful because potentially that medication could have interfered with her treatment. Once again, if you don't feel experienced or you want advice, liaise. As I said to you before, the on-treatment monitoring is minimal. At 12 weeks after the patient's completed treatment, you do the test for the HCV RNA. And in my case with Steve was cured, which was absolutely fantastic. We also checked his liver function tests at that 12-week test. They had reverted to normal, which is very common amongst this group of patients. One important thing that you do have to talk to the patients about is that while they have been cured of their hepatitis C, the RNA will be negative, but their serology will be positive for life. And that's really important because if they end up in the emergency department and their HCV serology is performed, it will come up positive. And it's really important that the patient knows that they can tell that clinician that they have been treated and cured. So just to summarise in terms of what pathology you're going to order. On the first pathology slip, when you're assessing if the patient's got a current infection, you want to put their ELFTs, full blood count, INR. You want to do their hepatitis C serology plus RNA plus genotype and viral load. You want to check them for co-infection with HIV and HBV. On the pathology slip that you do 12 weeks post-treatment, the key things you need are their ELFTs and their HCV RNA. If the liver function tests remain abnormal and you feel the patient needs further assessment, you can look up what tests are useful in that case by going to the Spot On Health website, and it will list all of the other tests that you should be doing, such as the alpha-1 antitrypsin, various autoimmune studies, and then you can refer the patient to a hepatology clinic for further follow-up. I have never done anything quite as satisfying as treating people who have viral hepatitis C. For a lot of those patients, having the virus is a monkey on their back. They worry about the future, which for them is about potentially liver failure or liver cancer, and they worry about the stigma and discrimination that people with viral hepatitis C face. So treating this can have a significant impact on that patient's well-being and their attitude to life in general. And so when you treat viral hepatitis C, you're not just treating a virus, you're treating a person, and it can have a significant impact on their health and happiness into the future. And I thought that this study from Hepatitis Australia was really useful in summarising what our patients with viral hepatitis C want to look forward to. They want to spend time with their loved ones. They want to be healthy for those around them. They want to maintain their ability to work and participate in the community, and they want to relish the ability to travel and be involved in their hobbies. So it's a whole of life experience that we can have an impact on by treating viral hepatitis C. In general practice, we manage lots of chronic diseases. A lot of them we can't cure, but it is very professionally satisfying as well to be able to cure a chronic disease by giving someone some medication which is easy to take, has minimal side effects, and is very effective in 12 weeks.